Yeah, if you go to slideshow, yeah, excellent. That part there.
Okay.
From beginning.
All right. Okay. I'm so sorry for the glitch, but nevertheless, I'll start my presentation. Mine will not be a very long presentation.
If you could go closer to the mic, Dr. Mangiza, because we are barely.
You can't hear me.
Yeah, it's faint.
How is it now?
Is it getting better? Thank you.
Getting better. Okay. All right. So as has been defined before, fetal growth restriction is defined as a fetal weight which is less than the 10th centile for gestational age. Okay. Infants are identified because they are born small for gestational age, with a birth weight which is less than the 10th percentile for gestational age, using specific growth charts. So, like what Dr. Slashfire had said, small for gestational age and fetal growth restriction are not necessarily synonymous, but in areas where there's a high prevalence of small for gestational age. In low resource settings, 1 in every 5 infants is actually born small for gestational age. Internet connection. Sorry, can you hear me? Hello?
Okay, we can hear you.
You can hear me. All right. So in low resource settings, I was saying 1 in every 5 infants, which is about 20% of infants, are actually small for gestational age. And small for gestational age contributes to 22% of neonatal age, so more than a fifth of neonatal age. And we find that the incidence of small for gestational age increases with decreasing gestation age. So when we assess these babies who are small for gestational age or who've got intrauterine growth restriction, we divide them into those with symmetrical intrauterine growth restriction and those with asymmetrical intrauterine growth restriction. The ones with symmetrical IUGR, it means that their head circumference is small and also their weight is small.
Guys, I think you may need to turn off one of the mics there, which are probably interfering with each other.
And their also there's a lot of echo.
Mics, I think in the same place. I don't know where Kuda is Kuda with you? I think one of her device is a mic.
Hello, Dr. Belena, how is it now?
We can hear you, but there's some muffling. Some people may need to switch off their volumes. Those who are not speaking, they should make sure the volumes, their devices are muted. Not just the mic, but the volume part. Yeah. You can try now. We can still see your screen, Doc. You just need to slide share.
Okay, all right. I think it's a bit better now. How is it now?
Yeah, we can see it. But we want to hear you. I think your mic is muted.
My mic is, but can you hear me now?
Your mic is muted. There's one mic for Kudakwashe which is not muted, but that mic we can't hear it. I think you muted the mic which you were using. You might want to mute the other one.
So we must mute one mic.
Yeah, we can't hear you. You may need to unmute. If you mute the host mic, I think the host mic is what you were speaking through. The Fetal Medicine Foundation host mic. Unmute the mic for the host device. The Fetal Medicine Foundation device is the one with the mic which was working. If you could unmute it. The mic.
Okay, it's unmuted. Can you hear me now? Hello? Hello?
Dr. Mangiza, or the team at the admin, they kindly unmute your mic so that we can hear what she's saying. Kudakwashe, your mic, we can't hear it, so allow the foundation one. I think that is what she was speaking through.
Unmute.
Yeah, it's better. Unmute it. You've muted it again. Just unmute it again, the foundation one.
Then mute it.
Yeah, okay now. Yeah, okay. Keep things the way they are. Then Kuda, you may need to mute your device because it's giving echoes.
I'm using Kuda's device right now. Or maybe should I use the other device?
Okay, because we can hear you. If you are seated next to your computer, you may be speaking through that computer because that is what you can hear.
Okay, am I echoing or it's okay?
Yeah, now better. You're now better. You could proceed.
Okay. All right. So I said we divide these infants into symmetrical IUGR and asymmetrical IUGR, depending on if the head circumference and the weight are both below the 10th percentile, then it is spared and the weight is below the 10th percentile, then that's asymmetrical IUGR. Symmetrical IUGR commonly occurs when the intrauterine insult occurs early in pregnancy. And we find that most of these babies with symmetrical IUGR may either have chromosomal abnormalities like the trisomies, or they might actually also have congenital infection. The babies with maybe with late onset preeclampsia.
Maybe we can use this as audio, and I can't hear those. So what are some
complications?
Okay, ndo yatirikushandisa for maslides. Ndanotice kuti yefoundation unmute futi, so I think those zvazvikonzeresa maecho. I don't know why it's. All right, so she can use my machine for the slides and then audio. All right, that's fine. That will be some. Okay. All right.
Am I unmuted?
I'm sorry for the glitches, but I think they are coming through. They are just having challenge where they are. Dr. Mangiza.
Okay.
Yeah.
Can I go ahead?
Yeah, you are more clearer now. Please go ahead.
Okay.
All right, I'm so sorry about this, so sorry about this. Anyway, so what are some of the complications that these babies face? We find that these babies come in, most of the time they come in prematurely. So there's prematurity which is involved when the babies have got fetal growth restriction. And there's always the debates whether the baby is better in or better out. That's always something that we need to discuss with the obstetricians and the perinatologists and the Fetal Medicine Foundation team, whether it's better to get this baby out or better for the baby to stay in. And then what we find is that babies who are small for gestational age plus preterm have a 10 to 40 times higher risk of mortality than the appropriate for gestational age counterparts. They are also at a high risk of perinatal asphyxia. So if they don't come prematurely, they come late. I mean, they're born either term or post-term. And then when they're born term or post-term, we find these babies most commonly in our public institutions that come out with perinatal asphyxia, encephalopathy, they come out meconium stained, and they get meconium aspiration syndrome, and they get persistent pulmonary hypertension of the newborn. And it's very difficult to salvage some of these babies when the fetal growth restriction is not recognized early and the babies are not taken out early, and then they come late with some of these complications, which we find very hard to deal with. They also have impaired thermoregulation. They tend to get hypothermic, so we need to nurse them in a warm place in order to maintain good temperatures. So we need to nurse them either in isolates or in incubators. Okay. And then they also have polycythemia and hyperviscosity. I think some of them, because of they're deprived of oxygen in utero, so they respond by getting polycythemic. And then they also have impaired immune cell function, so they're at a higher risk of getting infections. They have hypocalcemia, and they also have feed intolerance. Okay. So in terms of our management, when you let us know, when the obstetricians let us know that, you know what, we've got a baby who has we've got a fetus who's growth restricted, our management starts right in the delivery room. We need to be prepared. So preparation involves many things. It involves the if it's a preterm baby, under 34 weeks, we expect that the baby should get steroids. So I'd like to encourage our Fetal Medicine Foundation team that whichever centers they work in, it's good for them to actually be able to administer antenatal steroids to these mothers. I'll give examples that, sometimes in private, a woman might be diagnosed, fetal growth restriction, abnormal Dopplers, and then they say to the mom, the baby needs to come out early. And then mom needs to go for admission. But sometimes these mothers take quite a while to actually come to the hospitals for admission. So it's better if obstetricians or the Fetal Medicine Foundation team actually start by giving the steroids to the mother at their rooms or at the clinics where they are running, where they're seeing these women, so that at least the baby stands a better chance. So we also make sure that in the delivery room where we attend to these babies, it's a warm delivery room and with adequate equipment. And we also need skilled staff. So for centers like our Salimu Gabe, our government institutions like Salimu Gabe, we're always encouraging the obstetricians that when you have these high-risk babies, please make sure that you call the pediatricians, or it's pediatricians in quotes, because sometimes it might be the senior health officer who comes or the registrar, but it's good for these babies to be resuscitated by a team of people, as opposed to just having the midwife on her own resuscitating these high-risk neonates. Okay. And then when we admit these babies onto our wards, it's very important for us to actually accurately assess the weight of the baby. You don't know how important it is to actually get an accurate assessment of the weight. We also measure the head circumference and we measure the length. For us, most of our mothers don't have early ultrasound scans. If we're looking at centers like Salimu Gabe and Paringatwa Hospital, for us, the most accurate measurement of estimation of gestational age is by an early ultrasound scan, which is an ultrasound scan before 20 weeks gestation. So because most of our mothers at these public institutions don't have early ultrasound scans, we do a postnatal assessment of the gestational age. We use what is called a Ballard score, which is basically we're looking at the physical characteristics of the baby, we're looking at the neuromuscular activity of the baby, and we are also looking at the development of the baby, like the skin, the ears, the tone. And then we use this assessment to sort of assess the gestational age of the baby postnatally. But it can be off by 2 to 4 weeks, and it's also variable depending on the skill of the person who's doing it. And then we need to plot this gestational age and the weight on appropriate charts. So there's always a debate as to what is the appropriate chart to use. Currently at Sandi Mugabe, we're still using charts which are probably not appropriate. We're using what is called the Lubchenco charts, which were actually meant to be fetal charts. But I think we are pushing so that we move towards using the intergrowth charts, which is what we're now using in the private unit, because these charts have been tried and tested on babies from many different parts of the world. And then it's also important to do a thorough physical examination on these babies, looking for dysmorphism and for signs of congenital infections. Like I mentioned before, we manage these babies' thermoregulation. Most of the times, these babies require respiratory support. If they're premature, they require CPAP, which is continuous positive airway pressure. If they are term babies, they tend to have their meconium stained and may have meconium aspiration syndrome or persistent pulmonary hypertension of the newborn, and they may require either CPAP or mechanical ventilation or even high frequency oscillatory ventilation. They're at high risk of hypoglycemia, so we need to monitor their glucometers, especially in the first 12 to 36 hours. Nutritional support is also important because these babies were starving in utero. So we try to make sure that we feed them well after they're born. And then investigation for underlying causes are done where it's not known. Where we know that severe preeclampsia, we don't usually investigate, but find the underlying cause. Okay, and then these infants are at risk of neurodevelopmental delay and cognitive abnormalities. So we tend to do what is called high-risk follow-up, and this together with the developmental specialists so that we make sure that they reach their best potential. They're also at high risk of adult growth about this a bit. They're at risk of getting hyper, need to be followed up period, but even into adulthood. So just for a bit of statistics, I'm going to present to you a study which I did as part of my MPhil in neonatology, which is actually looking at this specific topic. So the title of this paper, which is soon to be published in Frontiers of Medicine, is called Morbidity. It was called Morbidity and Mortality in Small for Gestational Age, Very Low Birth Weight Infants in a middle income country. So I think this definition, we talked about it already. And then why we use small for gestational age, like I mentioned before, is because it's commonly used as a proxy for intrauterine growth restriction. And in settings with a high prevalence of SGA, it is most likely to be a result of fetal growth restriction. So I'll use the term SGA as the proxy for fetal growth restriction. Okay. So the burden of SGA is very high in low and middle income countries, and the mortality risk associated with being preterm and SGA is substantially higher than either alone. And yet the outcomes of these infants is not well described in low and middle income countries. Like I'll give you an example. The outcome GA preterm babies at our own unit at Sandi Mugabe is a known town where I was in neonatology. So the objectives of the study were to compare the mortality rates of SGA infants with appropriate for gestational age infants. And I also compared the morbidity rates of SGA infants with AGA infants. We know that preterm babies face different morbidities, so we wanted to actually compare, is there a difference between those who are SGA to those who are actually appropriate for gestational age? And then the last object versus those who are asymmetrically growth restricted. I think I'm symmetrical versus asymmetrical. Okay, so what I did is I obtained data from the Vermont-Oxford Network Grusa-Scale database. So the Vermont-Oxford Network is a very big neonatal network. It's based in America, but it's got they have many centers all over the world. So what they do is they collect neonatal data from different neonatal units all over the world, and then they collate it up and they come up with they produce papers, they come out with recommendations from the data that they collect in different centers. So Grusa-Scale Hospital in Cape Town, where I trained in neonatology, is part of the hospital collects data, which also is part of the Vermont-Oxford Network database. So it's actually a very low birth weight database, which enrolls infants from 401 grams to 1,500 grams. So only the small babies or the tiny tots are included in this network. So we included infants who were between 501 to 1,500 grams at birth and between 27 to 30 weeks gestation. So we chose 27 to 30 weeks gestation because we wanted to capture both the SGA and the AGA who are within the weight band 501 to 1,500 grams. So we excluded neonates with major congenital or chromosomal anomalies, and we also excluded our twins because we know that the twins come out SGA because of constitutional, being constitutionally small, not necessarily because of fetal growth restriction. So for gestational age, we used an early ultrasound, which is an ultrasound less than 30 weeks to estimate the gestational age. But unfortunately, Cape Town is also a middle income country. So only about 30% of the women actually had early ultrasound scans. So the rest of them, we used the Ballard score or the postnatal foot length were used to estimate the gestational age. We used the Fenton growth charts for this study, which is a bit debatable because Fenton growth charts are actually not meant for developing countries like South Africa, but that's what we were using at that time. And then mortality was defined as death before discharge. Respiratory distress syndrome, which is also synonymous with hyaline membrane disease, was defined as the need for rescue surfactant, and bronchopulmonary dysplasia was defined as the need for oxygen at 36 weeks post-menstrual age. Okay, and then we also looked at intraventricular hemorrhage, and this was defined according to Papill's criteria as grade 3 or 4, which is severe IVH. These babies were also screened for retinopathy of prematurity and defined as severe retinopathy of prematurity. We defined early onset sepsis and culture and late onset sepsis and culture. We worry a lot about late onset sepsis because we believe it's hospital acquired and that we clinicians have something to do with it. All right, so in my study, in this study, we enrolled about 1,800 infants between 27 to 30 weeks, and we found that 12.7% of them were actually small for gestational age. This is quite high. In developed countries, you find that only about maybe 5% or to 7% of their very low birth weight infants are actually small for gestational age. But our study found that about 13% were small for gestational age. So this is just a table showing some of the demographic characteristics. So the gestational age was synonymous between the SGA and the AGA. And as we expect, the birth weight was much smaller in the cohort amongst the SGA, with a mean birth weight of 799 grams in the SGA group. The head circumferences were smaller in the SGA compared to the AGA group. Most of the babies who were SGA, their mothers had maternal hypertension, as expectedly so. and 73%, almost 74% of the SGA group got antenatal steroids, possibly because the ones who are fetal growth restricted are diagnosed and there's time, whereas sometimes the AGA group is a mother who just comes in labor and she's actually not received any steroids. We found that there were more females in the SGA group than the AGA group, but the prenatal care and whether the babies were inborn or outborn was similar between the two SGA and AGA. All right, this is just another graph just showing the proportion or the percentage of infants by SGA. We see that at 27 weeks, about 10% of the cohort was SGA, whereas by the time we got to about 30 weeks, maybe about 30% of the cohort was SGA. Then the results, these are risk ratios for morbidity and mortality. So what we found is that the overall mortality in this study cohort was about 19.7%. So about 20% of the infants in this cohort died. But we found that the mortality was much higher in the SGA group. In the SGA group, about 29% of the infants died, whereas in the appropriate for gestational age group, it was only 18.5, and this was actually significant with 8.7. We also found rates of babies with bronchopulmonary dysplasia, necrotizing enterocolitis, and late onset sepsis in the babies with the SGA. I think those are the ones that are highlighted in bold in black. And then we also looked at the differences between mortality and morbidity in those who were symmetrically growth restricted versus those who were asymmetrically growth restricted, but we didn't find any differences. So we found a significantly increased risk of mortality among the SGA infants, and this is in keeping with other studies. The incidence of bronchopulmonary dysplasia was generally low in the study population, but it was significantly higher in the SGA group. So we find that these SGA infants get stuck on oxygen. There's a lot of theories which suggest that there's a lower prevalence of RDS in the growth restricted infants, because the theories say that because they are growth restricted, they get cortisol in utero, and then they tend to get less RDS, but our study did not find this difference. So if these mothers with growth restricted babies still need the antenatal steroids to help these babies, because there's actually no difference in the RDS between the two groups, according to our study. Okay, necrotizing enterocolitis was significantly higher in the SGA when looking at the entire population. So this suggests a high mortality for SGA babies who develop NEC. So what we found is that there was most of the babies who were small for gestational age died of had necrotizing enterocolitis. So we may have to, we might have to have protocols which actually make sure that the SGA babies get mother's milk, because if they don't, they're actually at a very high risk of getting necrotizing enterocolitis. And also SGA infants had an increased risk of late onset sepsis. Other studies have noted increased rate of use of central venous catheters due to delay in reaching full feeds. So what happens with these SGA infants, just from my experience, is that most of the time they've got feed intolerance. So in Cape Town, we were actually able to give total parenteral nutrition to babies who struggle with feeds. So the moment you start giving total parenteral nutrition and you're putting central lines in these babies, there's actually a high risk that they get sepsis and they can actually die from the sepsis. So our study also showed a high risk of late onset sepsis in SGA infants. So the strength, it was a large sample size study which was done I looked at data which had been taken over a 6-year period. It's good quality data. All the data which goes to the Vermont Oxford Network database is really scrutinized, and we've got strict and standard definitions, and there are people who are employed at Grootes Schuur Hospital to actually collect this data, who actually work specifically on collecting this data. But one of the limitations that we had is that only about 30% of the study population had an early ultrasound scan, which is a common problem or common issue in low resource settings like ours. So in conclusion, SGA, small for gestational age infants at GSH have approximately twice the increased risk of mortality compared to their appropriate for gestational age counterparts. They also have an increased risk of dysplasia, late onset sepsis, and necrotizing enterocolitis. So these findings are important for perinatal decision making, and this is a study that was done in Grootes Schuur Hospital in Cape Town, but can also be comparable. We know that these infants between 27 to 30 weeks, their risk of mortality is also high. So it's important for us when we are counseling the mother, and even for perinatal decision making. So this is just some of my references. So some of the take-home messages that I thought I'll just put through across from this presentation is that fetal growth restriction significantly increases mortality in neonates, and we need to accurately assess gestational age. We're really happy that there is the Fetal Medicine Foundation Society or team. It's important for us to encourage our mothers to book early and to have an early ultrasound scan so that we can actually have a good estimate of what the actual gestation of this neonate is. Like at Harare Hospital, we hardly ever see mothers with early ultrasound scans. And then we need to use charts that are suitable for our population. I talked about the intergrowth charts. And then we need to improve data collection on our outcomes. Sad to say, we at Salim Mugabe Hospital, we have the NeoTree, which collects data on outcomes of neonates. But at the moment, we're not yet collecting, we don't have any data that is specific for small gestational age. But just from our clinical examination, we can tell that most of the babies that are in that unit are actually growth restricted. And then there's always need for collaboration on perinatal decision making. As you, the obstetricians, see these mothers, it's important for us to discuss together as we make decisions and also as we counsel these parents. And then I'll just end my presentation with a slide of one of our pretty tiny tots. This was a little girl who our team managed. She was a growth restricted baby born at 28 weeks plus a couple of days with 800 grams. You can see that her head is a bit on the big side. It was an asymmetrical IUGR. She spent about almost 60 days in hospital and then finally discharged at 1.8 kgs. We struggled with feeding her, but we pulled through even without total parenteral nutrition. And that's a current photo of her now. She's 5 months and she's lovely. Thank you.
Thank you so much, Dr. Mangiza. Very eye-opening. I'll open the questions, some burning questions that we may have for Dr. Mangiza. I think the first two presenters were the opportunity to ask. Do you have any questions you want to ask Dr. Mangiza right away? We may pause, or if you're a panelist, you are more than welcome to speak on the questions. Well, probably while questions are coming, let me comment, Dr. Mangiza, and say I think I'm just happy that your study there showed us that there is a difference between babies who are SGA and those who are AGA, but more or less in the same weight category. I think if we could give you a challenge to say, I think on your indices, the ones you report, the perinatal indices, we know we are still doing the age categorization of babies, where we are saying between 500 and probably 1,000. What is the take-home rate? If we could subclassify those babies into those who are FGR and those who are not, I think it will give us a better message. Because honestly, you may be born 800 grams because you are 26 weeks. But if you are 29 weeks and they are born 800 grams, you can't have the same survival rate for sure. The other one was starved in their mother's womb. and they become malnourished, kwashoka in the uterus. The other one was just unfortunate that their mother's cervix was not strong enough to hold them inside. So all these issues, I think we need them to become more clearer so that the management protocols can address these babies according to their need.
Yes, that's very true, Dr. Verenga. We need to work on that. Like I said, currently our Neotree, which is the database that we have for Salim Gabe, is actually not classifying these babies into those who are fetally growth restricted or those who are appropriate for gestational age. But I think it's very important for us to do. And like I also highlighted to you, I think we actually need to start by dating the pregnancies accurately, because at Salim Gabe, we really struggle to actually get, an accurate assessment of gestational age, because the women have never had a scan. The last normal menstrual period is very, it's not a very good measure to estimate gestational age. So maybe if we will probably try and get accurate charts, but I don't know how we can encourage our women or to at least get an early ultrasound scan, or I don't know if we are able to get services for many women to get early ultrasound scans.
Maybe I may come through. Let me say for Salim Gabe, probably, I think we've sort of done a chunk, half a chunk of the women who come to Sally. They have a scan. I think it is now incumbent on your team to look for the dates which have been validated by the fetal medicine unit, because what we are trying to do in the fetal medicine unit throughout is all women we are seeing, we are trying to validate their dates by the best estimate. So you will see that Salim Gabe, I think 50% now, almost 50% of the women, except those who come already in labor, but anyone who gets admitted invariably has a scan from fetal medicine. So if you just encourage your team to check the ultrasound scan report that these women will be having in their books. But more than half of women, I can assure you, if their dates are validated by the fetal medicine unit team. So yeah, so it's something to check out. Do you have any questions for
Okay,
Dr.
I think we'll try.
Okay, for Dr. Mangiza,
and see if we can get more numbers with of women with actually validated scan.
Excellent, excellent. Any question for Dr. Mangiza? Dr. Mangiza told me that she's on call today. You know, they work as a team of 3 neonatologists and they rotate their call. So she actually took time off her call duties to come and present to us. And we really want to appreciate to express our appreciation to you, Dr. Mangiza. Thank you for making this sacrifice. We believe it will go a long way in improving our understanding of the small babies and also how they are looked after post-birth. So thank you so much for doing this, and we really appreciate it.
Thank you, Dr. Verenga. It was a pleasure. Thank you very much.
Thank you.